Hi, and welcome to Allied Health 209, Part 2 of Chapter 7 on Immunology. Okay, here's a nice little slide. It just kind of shows you the difference between the active and the passive and those natural and artificial. Okay, so still we're talking about these acquired specific immunities, right? So again, I'm trying to make sure you guys lock in the difference between this active and this passive. So our active immunity, again, is that long term, right? It's that protection against any future infections because now you have been exposed to the antigen and then and you form the antibody, and then those memory B cells remember that antigen, and now that person is immune because if they come in contact with that same pathogen, because remember we're talking about specific, those memory B cells will remember and launch an attack against it to prevent you from getting sick again. Okay, and again, passive, remember we talked about short-term protection, right? Okay, it's only temporary, and that individual receives antibodies from either a mother or from an anti-serum. They don't make them on their own. Okay. Okay, guys, so here's one of our activity slides. So a great way to use this slide is to pause this now, get out a piece of paper, and write down what you think each one of these would be. Is you receive a flu shot, is that active natural, active artificial, passive natural, passive artificial? So write down all the answers and then go back to the previous slides and check to make sure you're getting the right answers. This is a wonderful way to study. So pause this slide now, take out your paper, answer your questions, and then go back and see if you got the right answer. The slide previous to this is a very good slide to help you check to see if you got the right answers. So let's talk about classes of antibodies, immunoglobulins. Okay, antibodies are part of the globulin group of proteins, okay, that circulate in the blood and referred to as immunoglobulins, Ig, right? So how are immunoglobulins classified? They're classified into groups based on their shape, their location, and their function. So we want to talk about some of the immunoglobulins, okay, if given their function, okay? So IgM is the primary responder in the first encounter with an invading agent. Now, a way to think of it is IgM medic, like a paramedic, right? They're the first ones on the scene. They're the first responders that get to the sick patient and try to stabilize them to get them to the hospital, right? So think of IgM as a medic and that they're a primary responder in that very first encounter with whatever invading antigen we have. Then we got IgA, okay? IgA protects your mucous membranes from bacterial and viral infections. So kind of remember, mucous membranes, allergies, and things like that. That's a good study tip to help you lock down what IgA does. And then we're talking about IgD. It's involved in lymphocyte activation and suppression. So think of D, downers, and then uppers, right? We talked about this previously in part 1 of our immunology when we talked about activating these lymphocytes to go out and do their job, and once they're at that good job, to be able to then suppress them and let things go back down to normal. Then we have IgG. It responds to the invading antigen in subsequent encounters. So think of guard. They are not active duty, right? Okay, think of the guard. They're not active duty, okay? So they may not be that medic that responds with the first encounter, okay? When subsequent issues arise, we send out the guard, right? So then we have IgE. It's involving allergic reactions. Think of E for EpiPen. If a bee stings you and you have an allergic reaction, you get your EpiPen out and it stops it from going forward. That's just a good study tip. And remember, you spell out the woman's name, Madge, M-A-D-G-E. So as you're trying to memorize all these immunoglobulins, and how they respond or their function, use the word MAJ to remember each one of them, and then use these study tips to remember what they're responsible for. Again, here's a great thinking slide. I want you guys to, you have your piece of paper out. Just like before, when you went through immunology part 1, you should have out your study guide so you can fill out any of the blanks. Have out a blank piece of paper so that you can test yourself to make sure you're getting this information down for your test, okay? So you want to be able to name the immunoglobulins, right? MAG, right? M-A-D-G-E, right? So it protects the mucous membranes from bacterial and viral infections. IgA, remember? Mucous membranes, allergies, snot, runny nose, snot, coughing, sneezing, allergies, IgA. Okay, it is the primary responder in your first encounter with invading antigen. So pause this and see if you're getting the right answer. IgM, M for medic, right? Paramedic. It responds to invading agent in subsequent encounters. IgG, guard, right? We call out the National Guard in that second response to try to get things in order. It is involved in allergic reactions. IgE, remember EpiPen. I'm having an allergic reaction, I get my EpiPen. It is involved in lymphocyte activation and suppression. Remember downers and uppers, IgD. Okay, let's move on to some types of allergy testing. There's 2 types, okay? So immunology test visualize the specific reaction between an antigen and an antibody, okay? So we have in vivo immunology testing that takes place inside a living organism, okay? An antigen is injected or pricked into the skin to see if the body has an immune reaction to it, okay? Which is seen sometimes as a red welt or raised induation, like when someone has a TB skin test. Then there's in vitro. These are immunology tests that take place in a laboratory outside the body. Antibodies or antigens associated with the disease are detected in the body fluids by mixing them with their specific antigen or antibody and noting the reaction, chromatographically, or by observing a color reaction. So how do these in vitro immunology tests work? Because as lab assistants or medical assistants, we understand that CLIA waived testing is some of the testing that we may be doing working in physician's office, okay? So we're talking about enzyme-linked immunoassays, okay? Where a liquid body fluid specimen is absorbed and travels across a testing area that enzymatically changes color if the antigen-antibody reaction takes place. And an internal control must also turn color to prove the testing device is working. The control area is usually located just beyond the test area to ensure the solution has traveled all the way through the test area. Okay, so you can imagine, just like with a pregnancy test, there's that membrane there, right? That water can seep through, but that membrane has been impregnated with a type of reagent so that when the body fluid, something like urine, passes through that membrane, then it will come in contact with that antigen. And if the antibody is in the urine and then it comes in contact with the antigen that is, for lack of a better word, impregnated or laced onto that membrane, then a color reaction will take place and give you a positive test result. If the antibody is not present in the body fluid, such as the urine, and it passes through the impregnated membrane that has the antigen on it, there will be no antibody-antigen reaction, so you will not see a color change, okay? But just like I told you guys in lab, when you work somewhere, the most important thing first is when you open up a new test kit. Okay, it comes into your physician's office lab. It's wrapped in cellophane. You open it up. There could be 25, 50, 100 individually wrapped pregnancy test kits, right? Now, the first thing you're going to do is, due to your policy and procedure for your facility, you may need to label that kit on the date and time it was opened. You're going to check the expiration date, make sure it's all good to begin with, okay? And then you're going to run external controls, okay? And then you're going to log that you ran those external controls. You're going to make sure you take out any package inserts or booklets that come with that kit. Replace the old package inserts or booklets that you keep somewhere in your lab, okay? You run those external controls and document that you ran external controls, and then you just have to do that once for that kit. Remember, maybe a positive and a negative, or a high and a low. You run those, and then as you go through the rest of that kit, then all you have to do is make sure that your internal control works after that. So what do you call the type of immunology test where body fluid travels across a testing area that enzymatically changes colors when an antigen-antibody reaction takes place? That's a lateral flow, okay? Immunochromographic assay. The main thing to remember is that's that lateral flow. So we see 3 different kits laying here, right? So in number 1, this is before you do anything to the kit. This is what it looks like. You opened it new, right? Then you run your positive control and your negative control, because like I said, when you open a brand new kit, you always need to run external controls. So when you run your positive and negative external control for your HCG, for your pregnancy test, your controls should work on both of them. As you see in this example, you have a line on the C in both of these. And then the positive control shows a positive, which is the line across test, and the negative shows no line across test. So you know that this works. You record this in your log books, whether it's electronically or in a binder in your lab. And then going forward, as you use that kit, then you don't have to run external controls any longer, as long as your internal controls work. And then when a new kit comes in, or you open a new kit, then again, you'll run a positive or negative external control, log them, and then moving forward, you just make sure your internal control is working. Remember, we always document everything, right? So now we're still talking about these CLIA-waived enzyme-linked immunoassays. So we want to name 9 tests that use this lateral flow immunology. First one we just showed you an example of is a pregnancy test. Then there's bladder tumor associated antigen, mononucleosis testing, H. pylori, HIV. We talked about the fecal occult blood test, influenza A and B, strep A, and drug testing. These are 9 different tests that use lateral flow immunology. So what is the difference between direct test kits and indirect test kits? Okay, so direct test kits provide the antibody in the kit and test for the antigen in the specimen. Indirect test kits provide the antigen in the kit and test for the antibody in the specimen. So in both cases, whether direct or indirect, a color reaction occurs if both antibody and antigen are present and the results are recorded as positive. If the color reaction does not occur in the test area, the result is recorded as negative. And we always make sure that our internal control works. Okay, guys, so here's our case study. So again, get out a piece of paper, because you want to test yourself here to see if you're getting the correct answer. Now, these case studies are a great way for us to put together what we're learning in both lab and lecture to see if situations we may face out in the field, if we're able to use our knowledge and critically think through these scenarios and come up with the correct response. So Tamika Roberts presented to her physician's office with a cessation in menstrual flow. She had nausea and vomiting and moderate weight gain. The physician ordered a pregnancy test. A pregnancy test detects HCG, which is a hormone produced during pregnancy. Would the pregnancy test be testing for the antibody or the antigen? The antigen, okay? The antigen. Would this be direct or indirect testing? Direct, right? Because direct tests for the antigen, indirect tests for the antibody. Is this a lateral flow test? Yes, remember we named those 9 tests that all are lateral flow, and pregnancy test, which detects HCG, is one of those lateral flow tests. Are the results displayed chromatographically? Yes, you see that colored line. So guys, make sure that you're getting these answers right, because this is a way for you not only to test your knowledge and see if you're getting this stuff locked in your brain, but it also helps to see if you're truly understanding how this works. And this really is scenarios you will face when you're out working. Okay, guys, let's dive a little deeper into HCG, okay? Let's talk about what the hormone used to detect pregnancy is and where it's produced. So HCG, okay? It's produced by that villi of the placenta of the pregnant woman. So you can imagine as she becomes impregnated, right? Then she produces this villi, okay? And then the hormone is secreted from that villi. So when is HCG first measurable in urine and blood, and when does its levels peak? So about 1 to 5 days after conception, it's actually measurable in urine. And it peaks, which means it gets at its highest about 50 to 80 days after conception. So is HCG the antigen or the antibody? It's the antigen. If it doesn't say it's an antibody, then it is an antigen. That's a way to help you, okay? So how do we collect that specimen to do a pregnancy test? In a perfect scenario, right, the best scenario, you collect a first morning urine, because as we've discussed before, it will be the most concentrated and have the highest level of HCG. The urine specimen container must be free of detergent. Urine should be refrigerated if it's not tested immediately, and once refrigerated, it must be brought back to room temperature by letting it sit out for 1 hour prior to testing. Now, this throws people off sometimes because they say, well, Ms. Shepherd, I thought you said we're not supposed to leave the urine sitting out at room temperature. That is if it is at room temperature the entire time. We're talking about a specimen that we knew we couldn't test, so we immediately put it into the refrigerator, and the temperature of that urine, of course, dropped as it stayed in the refrigerator, which decreases the chance of bacterial contamination. We're not using this specimen first for urinalysis and culture. We're using it for pregnancy test, but we do need to bring that specimen back to room temperature, okay? But it's not been sitting out at room temperature that entire time. And we only need to bring it out and bring it to room temperature if we know we're going to test it the second it gets to room temperature. So we want to talk about some points to remember when you're performing a pregnancy test, okay? First and foremost, we always want to check our urine-specific gravity results. Levels below 1.010 may give a false negative results because of a diluted specimen, okay? So if the patient has had a tremendous amount to drink and we don't get that first morning urine, because as we know, sometimes they will do pregnancy tests on random urines, it is better to check that specific gravity just to make sure we don't get a false negative because of diluted specimen. You want to bring the test kit to room temperature prior to testing. And as I don't feel like I have to say this, but we always know we check those expiration dates, and we never want to use expired kits, okay? So do not use the supplies or reagents from one kit with another, okay? Always make sure, like I said before, when you open up your new kit, you take out any packaging that's in there. I don't care how long you've been doing this test, it's better to read through those directions in that package insert to make absolutely sure that the company has not changed something dealing with that kit. Because then you could be doing it incorrectly because you're doing it the old way, when most kits will highlight on the outside if they've made any major changes to the kit. It is the most professional and best practice to check those package inserts that come with the new kit, and then to find whatever binder you have in your laboratory that keeps copies of those. Take out the old copies, put the new copies in. Remember, when we're opening up a new kit, you always want to make sure you run external controls, a positive and a negative, okay? Like I said, never assume the instructions for different test kits are the same. It's a really good way to get caught. And remember, qualitative test results will show a negative or a positive. You chart as negative for pregnancy or positive for pregnancy. So again, here's one of our case studies. And guys, I can't tell you enough how important it is to be able to answer these correctly, because it is just telling you that you've taken what you've learned and you're able to critically think through a scenario that you may encounter while working as a medical assistant or a lab assistant, and you want to make sure you're able to critically think these case studies through and come up with the correct answer. So Ms. Ross presents with nausea, vomiting, bloating, and moderate weight gain. She was 2 months late on starting her monthly period. 3 months gestation, the doctor ordered a pregnancy test. What is the name of the hormone that increases in pregnancy? If she was pregnant, would this hormone be detectable by now? And how would you chart a positive test? Would this hormone be the antigen or the antibody? Now pause this, write the answers down on your piece of paper, restart the slide, and see if you're getting the correct answers. Okay, yes, we know HCG, right? HCG is the hormone that increases when you're pregnant, right? The villi produces that hormone. If she was pregnant, would this hormone be detectable by now? Yes, remember 1 to 5 days after gestation, okay? And when you chart it, you don't just say positive or negative, you say positive or negative for pregnancy. And we've talked, if it doesn't say antibody, we know it's the antigen. So what type sample is most commonly used for this test? How could you test to see if this sample was too dilute? Is this a lateral flow test? And does this kit have an internal control? Again, pause the slide, write your answers down, and make sure you're getting the correct answer. We know urine is the most commonly used sample. We can use any type of urine sample, random. But of course, first morning urine samples are the best because they're more concentrated, right? The best way to make sure your urine is not dilute is to do a specific gravity test, right? And it should be greater than 1.010. It is a lateral flow test, and it does have an internal control. How would you know if your office is following the correct procedure for the test kit? It has. Are they using the package insert that comes with this specific kit? I cannot stress to you guys enough how important it is that when you open up a new kit, and people get complacent because they've been using the same kit for 5 years, 6 years, and they just assume it's always the same. I can't tell you how many mistakes have occurred for assuming things of that nature. Don't mix kits, and when you open up your new kit, go find the package insert from the previous kit, dispose of it, and replace it with a new package insert after you have looked over it and made sure that nothing with the procedure for this kit has changed. So let's talk about mononucleosis testing. So what is the causative agent of mononucleosis? It's EBV, the Epstein-Barr virus, right? So let's talk about mononucleosis. It's called the kissing disease because it is transmitted by direct oral contact through saliva. It's an acute infectious disease frequently seen in teens and young adults. Okay? The clinical symptoms for mono are mental and physical fatigue, severe weakness, headache, fever, sore throat, and swollen lymph nodes. Okay, that's your clinical symptoms. They come in complaining of these, right? The hematological findings include increased reactive or atypical lymphocytes under your differential, and the immunologic testing shows an increase in heterophile antibodies to the antibody to mono. So when is the heterophile antibody first produced, and what % of patients develop it within 3 weeks? So it is produced by the 5th to 8th day after infection. 80% of patients have a detectable level of heterophile antibodies within 3 weeks of exposure or infection, right? In the 20% of patients who do not produce the antibody, the diagnosis depends solely on the clinical and hematological findings. And just for your information, the heterophile antibody is the name of the antibody specifically formed against mononucleosis. Most of the time, the antibody is not named. So again, make sure you're using this as a way to see if you're getting this stuff together, right? Miss Peterson, a 13-year-old girl, presented with extreme fatigue, sore throat, headache, fever, and swollen lymph glands. The doctor ordered a CBC and a mono test. What is the name of the antibody found in individuals who have mono? The heterophile antibody, right? So what blood cell would you expect to see an increase of when they did the differential, looked down in that microscope to count the white cells if they have mono? Reactive lymphocytes or atypical lymphs. So if her mono test was negative, would this mean she does not definitely have mono? No, right? Because 20% of the time, patients produce no antibody even though they do have mono. Is the mono test a lateral flow test? Does it test for antigen or antibody? And does it have an internal control? Yes. It is a lateral flow test. It tests for the antibody, and yes, it does have an internal control. So let's talk about Helicobacter pylori, okay? Helicobacter pylori. It is the causative agent of most, but not all, duodenal and gastric ulcers. Helicobacter pylori, or H. pylori, is a spiral-shaped bacteria. So how does it cause ulcers? Okay, this spiral-shaped bacteria, H. pylori, weakens the mucus lining of your stomach. Then because that mucus lining, which protects the inside of your stomach, is weakened, the stomach acid is able to penetrate the sensitive lining beneath the mucus layer, and the acid in the bacteria then cause an ulcer. So what are the symptoms of ulcer? You have this gnawing pain in the abdomen after eating and during the night. Symptoms are relieved by eating and taking antacids. Okay, so those are our symptoms. How do we treat it? How do they treat the ulcer? They give them antibiotics first that are going to kill the H. pylori, right? Because we've got to get rid of that. That's what's causing the problem. And then drugs that reduce stomach acid, and they may even give you something that helps coat your stomach, like Milana or something of that nature. So how does the immunology test work? It tests for the antibody to H. pylori. So Lacey Harris, a 42-year-old female, presents with heartburn, stomach pain during the night, and a peculiar sensation of hot water bubbling in the back of her throat. The doctor ordered the immunology test used for peptic ulcer. What is the name of the test for the bacteria that can possibly cause an ulcer? If the test is negative, does this rule out an ulcer? Okay. The name of the test for the bacteria that can possibly cause it is H. pylori, right? No, if the test is negative, that does not 100% rule it out. H. pylori is a causative agent most, but not all the time. Ulcers are formed from other things other than H. pylori. Does this test for the antigen or the antibody? Is it a lateral flow test, and does it have an internal control? It tests for the antibody. It is a lateral flow test, and it does have an internal control. How should the doctor treat this patient? Antibiotics and drugs to reduce stomach acid, right? We need to kill the bacteria that's causing the ulcers, and then we want to cut down on that stomach acid so that that area in the stomach can heal. And like I said, sometimes they'll give you things to help you coat your stomach just to help protect it until the mucus lining can become healthy again. So let's talk about the human immunodeficiency virus, HIV, okay? We know that HIV attacks and destroys WBCs. Helper T cells, CD4 lymphocytes, right, are the cells monitored with HIV. Transmission of HIV is primarily through sexual contact and the sharing of needles with infected persons. Remember, helper T cells protect the body against infection through cell-mediated immunity. They also help B cells produce specific antibodies through humoral immunity. So when helper cells are destroyed by the HIV virus or infection, the body becomes less able to fight infections and becomes more susceptible to opportunistic infections. So what point after testing positive with HIV does AIDS occur? So acquired immunodeficiency syndrome, or AIDS, is defined by the presence of life-threatening infections and life-threatening forms of cancer. So you can test positive for HIV and not have full-blown AIDS, right? So acquired immunodeficiency syndrome is when you start having these life-threatening infections and cancers because the virus has decimated your immunity so much that you're getting all these opportunistic infections. If you get, like most things, prevention is what we want. But if we can't prevent it and someone comes infected with the disease, the earlier we can catch things like HIV or breast cancer or prostate cancer, the sooner we can treatment and we can lessen the chances of them having the acquired immunodeficiency syndrome, which means we want to find out early if you're positive for HIV so that we can get you on a treatment to prevent you from having these life-threatening infections or forms of cancer. Okay, when handling specimens for HIV testing, healthcare workers should adhere to the OSHA's bloodborne pathogen standards, such as wearing PPE and disposing of contaminated materials in the proper place. As I always say in lab, think before you toss. But what I also say in lab is we treat all patients, whether they're newborn infants or 102-year-old sweet little older ladies, as if anyone could have a infectious disease. We want to always wear the appropriate PPE when handling any blood or body fluids, because we never know when someone could be positive for not just HIV, but hepatitis or any other pathogen. So make sure you never let your guard down. We bring this up with HIV because, of course, this is an example of a very possible deadly virus. But as we know, we must treat all blood and body fluids as if they could be infectious. Okay? So how do these reference labs test for HIV? So serum is typically what's used almost always in reference labs, and they're looking to detect the HIV antibody. The enzyme-linked I never can say this right. The enzyme-linked immunosorbent assay, ELISA test, is used first and is confirmed by that Western immunoblot method. So how do physicians' office labs test for HIV? Because that's what we're looking at, guys, because you're working somewhere, you need to know the policies and procedures for your particular facility, because your particular facility may want you to draw blood in a SST tube, a red top tube, spin it down, take the serum off, and transport it to a reference lab to be tested. Or your physician's office or your clinic or your lab may have a CLIA waived HIV test that detects the presence of HIV antibody. Okay? In that case, when we're talking about these waived HIV tests, they could, depending on what your particular physician's office or clinic is using, blood or oral specimens can be used. Oral Quick uses a specimen obtained by thoroughly swabbing the outer gum, both upper and lower. Now, the good thing about these CLIA waived tests is they're very easy to use. And it's like I tell you in class, as long as you are following the policy and procedure for your facility, and as long as you are following the directions per the manufacturer, then these are easy tests to do and easy tests to read. So how does this waived HIV test work? Okay, so the swab is placed in a vial with developer solution that provides results in 20 minutes. A positive test shows reddish purple lines in a small window in the testing device. Internal and external controls are provided in the kit, and we've talked about these internal and external controls and how they work for each kit. So you swab it, you take that swab, place it in a vial with a developer solution, set your timer, start your timer immediately, and immediately read your results at 20 minutes. And you always want to make sure your external controls have been ran and they were accepted and logged, and your internal controls work with each kit. So Demetrius Jenkins, a 29-year-old male, presented to his doctor with fever, chills, malaise, muscle aches, headache, nasal congestion, and a cough. The doctor ordered the immunology test for the flu and for HIV. The HIV test came back showing a color bar in the test and control window. What is tested for in this case? The antibody or the antigen? Is this a lateral flow test, and does it have an internal control? It tests for the HIV antibody. Okay, it is another one of our 9 different lateral flow tests, and it does have an internal control. How would you know if your office is following the correct procedure for the test kit it has? Right, guys, I can't say this enough. Are they using the package insert that came with that specific kit? How would you properly follow HIPAA and OSHA guidelines? You want to wear your appropriate PPE always, dealing with any patient, and you always dealing with any blood or body fluids. Dispose of your contaminated materials appropriately. Think before you toss. So now we're going to talk about fecal occult blood testing, okay? So how does this rapid immunochemical diagnostic test for fecal occult blood work, okay? The patient pierces a fecal specimen with the blue inner probe located inside the tube. After mixing the specimen with the buffer solution, it is mailed to the physician's office lab or testing lab. So you give them this kit, they take it home with them, okay? The directions are in there. You go over it with your patient before they go home. They collect a stool specimen with some container that you have provided them, okay? That comes with a little probe that's inside the kit. They take that probe and pierce a fecal specimen, okay? And then after mixing that specimen per the directions with the buffer solution, it is placed in a specific mailing apparatus that is provided to them, and then they mail it to either back to your lab where you read it, or it's mailed to some other different testing lab. So these are a little more advanced concepts. We're talking about agglutination reactions. These are non-CLIA wave tests, okay? So we're talking about agglutination reactions, okay? Agglutination occurs as a result of an antigen-antibody reaction that causes the visible lattice-like clumping together of blood cells or tiny latex beads. Okay, we performed one of these in the lab when we did our ABO testing. Okay, agglutination reactions are not CLIA waived and must be performed in a hospital or reference lab. And the reaction can be seen either as you see that middle slide, either in a test tube, or the bottom slide like we did in class on a glass slide. So blood type, right, ABO and RH is determined by agglutination testing. And we want to be able to name 4 reasons for determining blood type, okay? So make sure you study these 4 reasons to determine blood type. First of all, if you're going to get a blood transfusion, or if there's a possibility of you getting a blood transfusion during some type of surgical procedure, we do blood typing in ABO and RH typing to make sure that you get safe blood transfusions. If we're worried about the RH type of a mother and a baby, and a mother and a father and the possible baby, we're worrying about this, so prevention of hemolytic disease of the newborn. Also identifications of parentage, whether who's the parents of this child, and then forensic clinical evidence on if there's blood at a crime scene, whose blood type does it match, right? So still talking about ABO blood typing, so how many different types of inherited blood antigens are found on the surface of red blood cells? More than 300, okay? There are more than 300 inherited by the person blood antigens that are found on the surface of RBCs. So why are ABO and RH antigens the most important of these antigens? Because of their intense antigenic response when transfused to incompatible recipients. The stronger the reaction, the more important they are. And ABO and RH antigens have the most strongest reactions, which that means if you got incompatible ABO blood, you would have a much greater reaction, which could cause kidney failure or death. So how is ABO blood type determined? Okay, by the presence or absence of A and B antigens on the surface of your RBCs. So individuals with A antigens are type A, B antigens type B, both A and B antigens are type AB, and if you have neither A or B, then you are type O. Landsteiner discovered the ABO blood groups in the early 1900s. So what naturally occurring antibodies are present for the 4 blood types? So type A produces anti-B antibodies, type B produces anti-A antibodies, type AB produces no antibodies, and type A produces both A and B antibodies. So blood typing is performed to determine compatibility between a donor's blood and a recipient's blood. What would happen if a patient was given the wrong type of blood? If a blood antigen comes into contact with its corresponding antibody, the result is agglutination or clumping of the red blood cells, eventually leading to hemolysis, which is the breakdown of red blood cells. The clumped red blood cells cannot pass through the kidneys, which may lead to kidney failure. So what type is the universal donor and universal recipient? So O is the universal donor and AB negative is the universal recipient. So how is ABO blood type determined in the lab? So to determine the ABO blood type, the fact that specific antibodies react with specific antigens is used. So if anti-A agglutinates with RBCs, the blood type would be type A. Consequently, we go down the road, right? And you guys can read this. Same thing happens with B, right? And then if anti-A and anti-B agglutinate with the RBCs, then the blood type again would be AB. And if there's no agglutination in either A or B, then the blood type would be O. So determine the blood types of the following individuals. You guys are going to need to be able to do this on tests. So please use this slide as a way to test yourself. So pause it and try to answer each one of them. So Regina Taylor's RBCs react with anti-A but not anti-B. Take the time to write down the answer and see if you're getting it correctly. She's type A. Miss Monroe's RBCs do not react with anti-A but with anti-B. What's the answer? Type B, right? Miss Mims' RBCs react with anti-A and anti-B. A and B, right? She's type AB. And then Miss Walker's RBCs do not react with either anti-A or anti-B. So what is her type? Type O, right? Guys, make sure you go over this and study this. You're going to need to know this. It's really not hard once you get the premise down. So how is positive or negative blood type determined? So we got the ABO part. Now we're talking about the RH part, right? Those with the RH antigens D. This which comes with that positive and negative part, right? So those with that RH antigen, which is we refer to as D, on the surface of their RBCs are considered RH positive, right? They're RH positive and comprise about 85% of the populations, okay? Individuals who do not have that RH antigen D are RH negative. So if they do have it, they're positive. If they don't have it, they're negative, right? And they comprise about 15% of the population. So most people are going to be RH positive, which means they do have that D antigen on their red cells. So an RH negative person has no naturally occurring RH antibodies, called anti-D antibodies, right? Anti-D antibodies may be induced after an RH negative person receives RH positive blood. So if you are RH negative, okay, you do not have naturally occurring RH antibodies, anti-D. You don't have the anti-D, okay? So if that person gets blood that is RH positive, or if an RH negative mother, let's say she's RH negative and the husband is RH positive, right? They have a baby and that baby is RH positive, then she's going to be exposed to that and will build antibodies against it. Which, that brings us to hemolytic disease of the newborn. It is a hemolytic anemia, okay? They're jaundiced, they have an enlargement of the liver and spleen, and that shows up in those newborns, all right? They can cause cardiac failure, respiratory distress, and death often occurs. It results from a mother who is RH negative who forms the anti-D antibody after the birth of her first RH positive child due to the mixing of the baby's blood with hers at birth. Hemolytic disease of the newborn would not occur with this first child. So think of it like this. She's negative, her husband's positive, she gets pregnant, her first baby is RH positive. Okay, as she gives birth, there is some mixing of the baby's blood, which is RH positive, with the mother's blood, which is RH negative. So her body sees that anti-D as foreign and she produces antibodies to it. Now that baby is born, so it doesn't affect that. She gets pregnant a second time. If her baby is RH positive again, then we can see where that antibody is going to attack the baby's cells because it sees that anti-D is foreign, and then it can kill the second child. So how can HDN be prevented? So hemolytic disease of the newborn can be prevented by the injection of the anti-D antibody or RhoGAM during and after the pregnancy of the RH negative mother. RhoGAM prevents the mother from becoming synthesized to the RH antigen. Be able to describe in your own words how RH incompatibility affects unborn babies. Include firstborn and subsequent birth babies, how the mother's blood type is connected, and how RhoGAM works. Okay? So be able to do that and make sure that you understand that when she gets pregnant, she's negative, her husband's positive, the baby happens to be positive. It doesn't affect that baby, right? Because just like when you get sick with the chicken pox, right? Okay, you get sick with the chicken pox, you build up the antibodies to that chicken pox virus. You get better, okay? Then you come in contact with it again a year down the road. You don't get sick with it the second time. Think of that when you're talking about the baby, because when she comes in contact with her firstborn RH positive baby, she has not come in contact with any of that before, so she doesn't have it built up in her system. The birth of that child makes her build it up because there's an exchange of blood at delivery. Now it's flowing around in her bloodstream when she gets pregnant with her second child. If that baby is Rh positive, then and she doesn't get the RhoGAM shot, then she can cause hemolytic disease of the newborn to develop in her second child. Now, another thing we need to remember is we're talking about if she's negative and the first baby's positive, and she's negative and the second baby is positive. What if the second baby is negative? Okay, so keep these things in mind as you run through this case study. If Tamika James's blood type was positive, if she was carrying a positive baby, could the baby develop hemolytic disease of the newborn? No, because she's positive, they're positive, right? No problem. If Candace Barr is negative and her baby is negative, could the baby develop hemolytic disease of the newborn? Pause this and see if you're getting the right answers. No, right? Because she's negative and they're negative. Would hemolytic disease of the newborn affect the first child of Sandy Carlton, who is negative, and her baby, who is positive? No, because the mother would not produce any Rh antibody until after the birth, because at birth is when there's the mixing of the blood, and then she develops the Rh antibody. So it will not affect the first child. True or false, when a negative mother receives a shot of RhoGAM, the physician is actually giving her anti-D antibodies. That's true. That is what's happening. And remember, okay, you need to stop and think these things through, okay? If the mother's negative and the baby's negative, we don't have a problem. If the mother's positive and the baby's positive, we don't have a problem. If the mother's negative and the baby's positive, and this is her very first pregnancy, we don't have a problem with that pregnancy, but then what we have to worry about is her pregnancies after then. But let's say her second pregnancy, she's negative, and the second baby is negative. Then we don't have a problem, okay? But because they won't know that, right, then we need to give her that RhoGAM shot just to make sure if she happens to be pregnant with another Rh positive baby, we don't end up with that child having hemolytic disease of the newborn. So let's talk about quantitative analysis, okay? When a quantitative enzyme-linked immunosorbent assay, ELISA test, most commonly used, are they CLIA waived? Okay, for allergy testing, the answer to that is no. So what does the term immunosorbent mean? It pertains to the attachment of an antigen or an antibody to a solid surface such as latex beads or wells in plastic dishes or plastic cartridges. Okay, so we're talking about antigens or antibodies, okay, that we take those antigen or antibodies and we put them on latex beads, or we put them on the inside of a little plastic well or a dish, or we take this little plastic cartridge and put them on that cartridge, okay? So how does the enzyme-linked ELISA test work? So the antigen is fixed to the well in a plastic dish. Okay, the well is rinsed. The serum specimen containing the antibody is added. The well is then rinsed to remove anything that does not bind. Next, an enzyme antigen that will bind to the antibody is added, and the well is rinsed again to remove any enzyme that is not fixed. An enzyme color developer that will react with the enzyme is added. If the serum contains antibodies specific to that antigen, a color change will occur. The more antibody present, the darker the color. Guys, this is not hard, but pause this slide and read through this a few times so you can make sure that you're understanding it, okay? Remember, if there's an antibody in there that is specific to that antigen, then there will be a color reaction. The more antibody that is in there, the stronger the color change. Okay, guys, let's talk about antibody titers, okay? What is a titer? So it's a quantitative, and it's non-CLIA wave, right? And it's a method to determine the amount of a specific antibody in the blood, such as your antibody against measles, okay? It's looking for that specific measles antibody that is in your blood, okay? It is a test that measures the extent to which an antibody can be diluted before losing its power to react with that specific antigen against something like measles, right? A series of dilutions, like 1 in 10, 1 in 20, 1 in 30, right, of that antibody is made. The weakest dilution, okay, that still shows a reaction is reported, okay? So if we draw your blood and we're wanting to see how much antibody to the measles virus you have in your blood, we put it in a test tube and we dilute it out. And then we add the antigen. There's going to be a reaction. What we're looking for is how little antibody is there and you still have a reaction. And then we have guidelines that tell us that depending on the titer, where it lies tells us if you're still immune or not. And immunity is what we're looking for, okay? And titers are one way that we can tell if you are still immune or not, or how immune are you. You may not show any immunity, or you may show immunity and it's weak and we want to give you a booster shot, right, of your measles vaccine. So that's how that works, guys. But pause this slide and read over this. You may read it a couple times just to help kind of click it in for you, okay? Now, so how is a titer used to treat hemolytic disease of the newborn? So a titer provides the physician with information about the quantity of antibody in that patient's blood. So a series of Rh antibody titers monitors the degree of sensitivity the mother might develop against her Rh positive baby's cells during the pregnancy. If the titer begins to rise, then the doctor can take appropriate measures to protect the baby. So guys, that's the end of part 2 on chapter 7 on immunology. And remember, we talked about the immune process, how to differentiate between cell-mediated humoral immunity. We talked about 4 ways to acquire adaptive immunity. We talked about the classes of immunoglobulins, which are antibodies, right? The principles of the in vivo and in vitro immunology test. We talked about direct and indirect immunology tests. We talked about those tests like pregnancy test, mono, H. pylori, and others, right? We also talked about those CLIA wave tests for HIV. We also talked about ABO and Rh blood typing, how Rh incompatibility can cause erythroblastosis fetalis, which is hemolytic disease of the newborn. We talked about advanced immunological techniques such as agglutination and the ELSA and the chromographic immunoassay. We talked about titers and how they're used in the diagnosis and prognosis of things like if you need a booster shot because your immunity has weakened from when you got your immunizations when you were a child, to tracking the sensitivity in mothers to try to change directions or make adjustments to treatment to try to protect that Rh positive baby. So remember, go back to part 1 of chapter 7's presentation and use the opening slides to study your key terms, okay? And now you can use the following slides to study. I'm just going to quietly go through these slides, okay? I'm not going to talk, and I'm going to go through them relatively quickly, okay? Because what I want you to do is use the key term slides from part 1 and these slides as a way to test your knowledge, like you would use flashcards. So I'm just going to quietly go through these slides quickly. You guys can pause them, rewind them, and use them as a study tool. Okay, guys. So this is the last of the chapters. All the other chapters are that needed to be up online are up online, and I will see you in class. So make sure you study. Make sure that you use these slides as a way to test your knowledge.